There is a number that millions of older adults are chasing every single day, checking their blood pressure monitors, adjusting their medications, worrying when it goes up, and feeling relieved when it comes down. That number is 120/80, the textbook definition of a perfect blood pressure reading. But here is the truth that most people over 60 are never told, and it is a truth that can genuinely change how you understand your own health. That number was not established with older adults in mind. It was built around the cardiovascular physiology of middle-aged adults, and applying it rigidly to someone in their 70s or 80s is not just potentially unnecessary, it can actually be harmful. Stay with us until the end of this video because by the time we finish, you are going to understand blood pressure in a completely different way, and you are going to have a much clearer picture of what your numbers actually mean for your specific situation. Let's start with some basic but genuinely important biology, because understanding how blood pressure changes with age is the foundation for everything else we're going to cover. Blood pressure is simply the force of blood pushing against the walls of your arteries as your heart pumps. The first number, systolic pressure, measures the force during a heartbeat. The second number, diastolic pressure, measures the force between beats when the heart is resting. In younger adults with flexible, elastic arteries, blood flows relatively easily, and the pressure required to push it through the system is lower. But as people age, arteries naturally lose some of their elasticity. The arterial walls become slightly stiffer, and the heart has to work harder to push blood through a less flexible system. This is a normal part of aging, not a disease, and it means that blood pressure readings in older adults are naturally and appropriately somewhat higher than in younger adults. The question that modern medicine has spent decades debating is exactly how much higher is acceptable, beneficial, or even necessary in order to keep blood flowing adequately to the brain, kidneys, heart, and other vital organs. This debate became much more prominent when researchers began noticing something unexpected. When doctors treated older adults very aggressively to bring their blood pressure down to the same targets used for younger patients, some of those older adults started experiencing dizziness, falls, fainting episodes, kidney function decline, and in some cases, faster cognitive decline rather than slower. This finding was counterintuitive to many in the medical community because the assumption had long been that lower blood pressure was always better for the cardiovascular system. What the research was revealing, however, was that for some older adults, particularly those in their late 70s and 80s, blood pressure that is too low is actually as dangerous as blood pressure that is too high, because the aging body needs a certain level of pressure to deliver adequate blood flow to organs that can no longer compensate as effectively for fluctuations. This concept has a name in medicine. It is called the J-curve phenomenon, referring to the shape of the graph when you plot blood pressure levels against cardiovascular risk. The graph doesn't simply show that risk decreases as blood pressure goes down. Instead, it shows that risk decreases as blood pressure comes down from very high levels, reaches a lowest risk point somewhere in the middle, and then actually begins to rise again as blood pressure gets too low. For older adults, this J-curve tends to be particularly pronounced, meaning the range of blood pressure that is genuinely optimal is different from the range that is optimal for a younger person, and understanding where that range sits for you specifically is one of the most important conversations you can have with your doctor. So what does the research actually say about blood pressure targets for older adults? This has evolved significantly over the past decade. For many years, the general guidance was to treat everyone to a target of below 140/90, and later guidelines pushed for below 130/80. But large studies specifically focused on older adults have provided more nuanced findings. One major study found that more intensive blood pressure lowering in older adults did reduce some cardiovascular events, but it also significantly increased the risk of kidney injury, low blood pressure episodes, fainting, and falls leading to serious injuries. Another analysis found that among adults over 80, a systolic blood pressure in the 140 to 150 range was associated with better outcomes than either higher or lower readings, suggesting that the ideal target genuinely shifts upward with age. The current thinking among many geriatric medicine specialists and cardiologists who focus on older patients is that there is no single perfect blood pressure number for all older adults. The appropriate target depends on multiple factors that are unique to each individual. It depends on whether the person has a history of stroke, heart attack, heart failure, or kidney disease, all of which may shift the balance toward more aggressive treatment. It depends on whether the person experiences symptoms of low blood pressure such as dizziness on standing, lightheadedness, or frequent falls, which may suggest current treatment is already too aggressive. It depends on the person's overall frailty and functional status, since a robust, active 75-year-old may tolerate and benefit from tighter blood pressure control in a way that a more frail 85-year-old with multiple conditions may not. And it depends on the quality and consistency of blood pressure measurements, since the single reading taken in a doctor's office is often not an accurate representation of a person's true average blood pressure across different times and situations. This brings up an issue that deserves far more attention than it typically receives, which is the problem of white coat hypertension and masked hypertension in older adults. White coat hypertension refers to blood pressure readings that are significantly higher in a clinical setting than they are in everyday life, simply because of the anxiety, stress, or anticipation associated with a medical appointment. Research suggests this phenomenon is extremely common and becomes more prevalent with age. Older adults who have white coat hypertension may be receiving and taking blood pressure medications that are entirely unnecessary based on their actual everyday blood pressure, and those medications can push their real-world blood pressure dangerously low. On the other side, masked hypertension refers to blood pressure that appears normal in the doctor's office but is actually elevated in daily life, which can lead to a false sense of security and mistreatment that is genuinely needed. Both of these phenomena highlight why home blood pressure monitoring, done correctly and consistently, is so valuable for older adults. It provides a picture of blood pressure that no single office reading can capture. Let's talk about what correct home blood pressure monitoring looks like, because many people do it in ways that produce unreliable readings without realizing it. Blood pressure should be measured after at least 5 minutes of quiet sitting, with the back supported, feet flat on the floor, and the arm resting at heart level. It should not be measured immediately after eating, exercising, drinking caffeine, smoking, or experiencing significant stress. The cuff should be the correct size for the arm, since a cuff that is too small will give artificially high readings and a cuff that is too large will give artificially low ones. Measurements taken 2 or 3 times in a row and averaged are more reliable than a single reading. And measurements taken at the same time each day, ideally both morning and evening, over a period of at least 1 to 2 weeks, give the most meaningful picture of actual blood pressure patterns. This kind of systematic home monitoring is something that many doctors now actively encourage in older patients, precisely because it provides the context that isolated office readings cannot. It's also important to understand the specific concern around systolic blood pressure in older adults, which tends to receive more clinical attention than diastolic pressure for this age group. As arteries stiffen with age, systolic pressure tends to rise while diastolic pressure may actually fall, a pattern called isolated systolic hypertension. This is the most common form of high blood pressure in adults over 60, and it is genuinely associated with increased cardiovascular risk when it reaches very high levels. However, the diastolic component matters too, because diastolic pressure represents the pressure filling the coronary arteries during the heart's rest phase, and if diastolic pressure falls too low, the heart's own blood supply can be compromised. This is one of the key reasons why very aggressive blood pressure lowering in older adults can sometimes cause more problems than it solves, as bringing systolic pressure down aggressively may simultaneously push diastolic pressure into a range where coronary perfusion becomes inadequate. The conversation about blood pressure medications in older adults also deserves honest attention. Blood pressure medications are among the most commonly prescribed drugs for people over 60, and for many older adults they provide genuine, meaningful protection against stroke and heart attack. But blood pressure medications in older adults also carry risks that are not always fully discussed. Dizziness and orthostatic hypotension, which is a sudden drop in blood pressure upon standing, are significantly more common in older adults taking these medications, and they are a major contributor to falls, which are themselves a leading cause of serious injury and loss of independence in this age group. Some blood pressure medications affect electrolyte levels in ways that require monitoring and can cause dangerous imbalances if not managed carefully. Others interact with commonly used over-the-counter pain medications in ways that can affect kidney function. None of this means these medications should be avoided. It means they should be used thoughtfully, with regular reassessment, and with clear communication between patient and doctor about symptoms and side effects. One of the most important but least discussed aspects of blood pressure management in older adults is medication review and deprescribing. As people age and their health status changes, medications that were appropriate and necessary at 65 may be less necessary or even counterproductive at 80. The practice of periodically reviewing whether each medication a person is taking is still providing more benefit than risk is something that many geriatric medicine specialists consider a critical part of good care for older adults, but it happens far less often than it should in routine medical practice. If you are an older adult taking blood pressure medication and you have never had a conversation with your doctor specifically about whether your current target and current dose are still appropriate for your age, current health status, and current symptoms, that conversation is worth initiating. Diet and lifestyle remain genuinely meaningful contributors to blood pressure at every age, and it's worth mentioning them not as a replacement for medical management but as important complements to it. Let's also spend a moment on something that doesn't get nearly enough attention in discussions about blood pressure for older adults, which is the significant difference between blood pressure readings taken with the patient sitting versus standing. Orthostatic hypotension, the drop in blood pressure that occurs when a person moves from sitting or lying down to standing, becomes increasingly common with age and is a direct contributor to dizziness, lightheadedness, and falls in older adults. What makes this particularly relevant is that a person's seated blood pressure reading may look perfectly managed on paper while their standing blood pressure drops to levels that are dangerously low the moment they get up from a chair. This postural drop can be caused by the medications being used to manage their seated blood pressure, creating a situation where treatment that looks appropriate in the clinic is actually causing real harm in everyday life. Doctors who specialize in older adult care often routinely measure blood pressure both sitting and standing for exactly this reason, and if your doctor has not done this with you recently, it is a simple but genuinely important test to request. There is also a meaningful conversation to be had about blood pressure variability versus average blood pressure, and why variability itself is a risk factor that often goes undiscussed. Most people think about blood pressure as a number, but blood pressure is actually a constantly fluctuating measurement that changes throughout the day in response to activity, stress, meals, posture, and dozens of other factors. Research has increasingly shown that high variability in blood pressure readings, meaning large swings from high to low throughout the day or from one measurement occasion to another, is independently associated with worse cardiovascular outcomes in older adults, separate from what the average reading actually is. This means that someone whose blood pressure swings dramatically from very high to very low throughout the day may be at greater risk than someone whose blood pressure is consistently at a somewhat elevated but stable level. Home monitoring over multiple days and times is the only way to capture this variability, and it is another reason why relying solely on occasional office readings gives an incomplete and potentially misleading picture. Understanding the role of the autonomic nervous system in blood pressure regulation also adds important context for older adults. The autonomic nervous system, which controls involuntary functions like heart rate and blood vessel constriction, becomes somewhat less responsive and less precise with age. In younger adults, the autonomic nervous system makes rapid, fine-tuned adjustments to blood pressure in response to changes in position, activity, emotional state, and other triggers. In older adults, these adjustments happen more slowly and less accurately, which contributes to both the greater blood pressure variability discussed above and the orthostatic hypotension that makes getting up from a seated position potentially hazardous. This is why the advice to rise slowly from sitting, to pause at the edge of the bed before standing, and to hold onto something stable when first standing is not just a general safety recommendation but a direct response to a real physiological change in how the aging nervous system manages blood pressure moment to moment. Reducing sodium intake is one of the most consistently evidence-supported dietary interventions for blood pressure, and it becomes even more relevant with age as the kidneys become somewhat less efficient at excreting excess sodium. The DASH diet, which emphasizes vegetables, fruits, whole grains, lean protein, and low-fat dairy while minimizing processed foods, refined sugar, and red meat, has substantial research support for blood pressure management in older adults. Regular moderate physical activity, even walking for 30 minutes most days, has been shown to reduce blood pressure meaningfully. Maintaining a healthy weight, limiting alcohol, managing stress, and getting adequate sleep are all factors with direct biological connections to blood pressure regulation that should not be underestimated simply because they are not as simple as taking a pill. Before we close, it's worth saying clearly that this video is for general educational awareness only. Nothing here should be taken as personal medical advice, and no one should change their blood pressure medication or targets based on a video without speaking directly with their own doctor. Blood pressure management is genuinely individual, particularly for older adults, and the right target for you depends on your complete health picture in a way that only someone with access to your medical history can assess. What this video can do is give you a better foundation for that conversation, so you can ask better questions and understand the answers more fully. If this video helped you see your blood pressure numbers in a new and more complete way, please share it with an older adult in your life who might benefit from knowing this too. If you found this video helpful, please like it and subscribe to Dr. William Hart Health for more videos like this every day.